Welcome everyone to the ambulance transports due to mental health. This is a common question that we receive, and so we wanted to hopefully address the issues and the questions that we have. My name is Tom Ryan. I'll be your presenter today. Today I'm joined by Leanne Foster. She's a friend of mine, but also on my team. She's going to be the one responding to those technical questions, helping me with chat. Later on, she'll help monitor and make sure I get the questions that you put into the chat. So again, please put questions in the chat if you have them. Our goal with this webinar is to help you define when Medicare will cover a transport when it is related to mental health reasons. Now, there's a variety of different reasons and a variety of different things that go with mental health. Someone asked about diagnosis codes. We're going to cover some of those basic billing criteria as well, so please be aware of that. All right, what do you got to know before we get started? This is our information. This information is current as of today. I did verify everything is good and nothing seems to have changed. We don't have any of that. However, after presenting, if something changes, that can happen. Medicare, you are required to know the Medicare rules and regulations, and the most relevant information is available on the Center for Medicare and Medicaid websites. Now, keep in mind for ambulance transports, our benefits have been maintained the same primarily, but the mental health benefit hasn't changed in a long time, so we'll get through those different questions you have. As I said, I did take pre-submitted questions and I will take questions in the chat, which means that I will give you the answers based on the questions and the facts that you give me. One thing that has happened in the past is people have tried to quote an answer that I gave, but then given additional information or remove some of the information, and this can change the answer that I would have given and the information. That's why you always have to go back to the CMS website, those current rules and regulations, and make sure you're following them. We'll let you know that CMS does prohibit the recording of this presentation for profit-making purposes. What I am doing is actually recording it, so the recording has started. What we will do then is use this recording as an encore presentation on our YouTube channel, and you'll have the opportunity to view it from there if you need it. You can take 60 to 90 days, and you'll be able to go ahead and go to our website 60 to 90 days, and what you'll get from our website is the information or the presentation, I'm sorry, is the presentation in a player, but the actual recording will be on YouTube. So keep that in mind as you go through. When we look at the goal today, it is to help determine if Medicare will cover your transport for a mental health reason. Now, your transport is the transport being provided when the predominant reason is mental health. In other words, there isn't a medical reason, and we'll talk more about that as you try to determine this. So with that said, I will need to define the ambulance transport benefit. I will explain the documentation to support medical necessity, and then I really do want to answer your questions in some of those scenarios that you provided. All right, next, of course, there are a few acronyms. These are just some common acronyms I will use. Hopefully most of them are familiar with you if you are working with Medicare. So life support or ALS, basic life support, BLS. CFR is the Code of Federal Regulations. CMS, the Center for Medicare and Medicaid Services. DOB, date of birth. EMT, emergency medical technician. IPF, inpatient psychiatric facility. IOM, internet only manual. PCS, physician certification statement. And SCT, specialty care transport. One thing I do want to mention is when I use the term EMT, in some states, an EMT is not defined as a paramedic. CMS defines an EMT in 3 levels: basic, intermediate, and paramedic. Your state may use different terminology, whether they use an EMT as a paramedic or not. Doesn't matter. We're going to use the 3 levels that CMS does. So again, basic, intermediate, and paramedic. Unless I specify, remember, I'm looking for an EMT in general, which could be any of the 3 levels. All right. So let's talk about the ambulance benefit in general. Now remember, this is your basic starting point because every ambulance transport has to meet the ambulance Medicare benefit requirement. These are set up in the Social Security Act and some of the other regulations that we're going to talk about. So the area and the question that we're looking at for this one is, does Medicare cover ambulance transports for mental health? The basic answer is yes, we can consider them, but they must meet the ambulance transport requirements. What does that mean? And so one of the interesting questions that I got during the pre-submitted questions is if we're going to start paying for this type of transport. Medicare has always paid for this type of transport. On the other hand, the documentation is what has limited us in some situations during reviews and other items. So yes, Medicare will pay for an ambulance transport for mental health. The thing that you must do is establish that the EMT evaluation meets the Medicare coverage criteria, or the transport is medically necessary based on the EMT evaluation. Now, did everyone catch that the medical necessity is what we're looking for? And who establishes that? The EMT during their evaluation. So there's a couple of key things there. Now, one of the other questions is, does every claim for mental health get reviewed when it's an ambulance transport? And the answer is no, it's not an automatic review. If you're on a review for a different reason, then yes, we could review it. If you bill certain codes, there are certain ones that we will look at. But assuming that everything is good, we assume medical necessity is met. We assume that if we request your documentation on a post-claim basis, it will support the fact that this is medically necessary. Now, the assumption doesn't just stop with us. The assumption stops until someone medically reviews it and proves otherwise. Who else could review it? Well, we're your Medicare administrative contractor. We're one entity. The recovery audit contractor is another entity, and they're looking at these different things. They're called the RAC. The Office of Inspector General, or OIG, also performs medical review. Now, if you get into a fraud and abuse situation, there's a couple other contractors that are involved. So there's a variety of different things going on there, but please remember, we will assume your claim is medically necessary unless you bill it otherwise or unless medical review occurs. And we'll talk more about that statement in a little while. But I wanted to bring up this question because it has definitely thrown people off, and we definitely did get some questions right away regarding it. So the one question that I did receive was, how do I know what medically isn't considered medically necessary for Medicare? And my basic answer to you starts with the Social Security Act, and it's Section 1861 S7. This is different than the basic medical necessity section in 1862 A1A. On the other hand, this section of the law states ambulance services where the use of other methods of transport is contraindicated by individual's condition, but only to the extent provided in regulations. Now, we're going to talk more about some of the regulations, but the key thing out of that Social Security Act is transport is contraindicated. How does that work with Medicare? So the first thing, it has to be the only safe means of transport. Doesn't mean the only available means of transport, the only safe mean. So it's 3 in the morning and there's a different means available and this person's having a mental breakdown, whether it's anxiety, whatever the situation is, they're not at risk to themselves. They're not trying to commit suicide, and they're not doing any of that. They're just out of control or they're irate. Does that mean that this transport will be covered? And the answer is, why was it the only safe means? If there had been a wheelchair van, would that have been safe? If there had been a family member available to take them, would that have been safe? And that's what you're starting to answer when you're looking at the assessment. That's what makes it medically necessary. What is the need for the EM during the transport? Not just that they're being transported, okay? When we look at the need for the EMT, one, are they doing medical monitoring for whatever reason? We'll talk about this. Are they using medical skills? What training was required? What's happening with this patient? And then the last part is you do have to transport them. You have to transport them. This was a question that was asked and they said, well, we didn't actually transport them. Do we have a billable service? And the answer is no, we don't have a billable service for Medicare. It has to be a safe transport. And so because it is a transport method, there we go, it has to be a transport. Now, what happens is the Center for Medicare and Medicaid Services takes that basic statement, and this is CMS, and what they do is then publish information to help you follow through. And this is in the Code of Federal Regulations, 42 CFR section 410.40. The link to it right here. Now, this is actually how CMS interprets all of this. So what we're going to go through and do is talk about the interpretation as it relates to mental health, but as it also relates to the overall ambulance benefit. Along with that, CMS does provide us and you with information on claims processing and the benefits for ambulance. These are done in two sources. So not only do they interpret the law in the CFR, they then take it a couple of steps down and provide daily operating instructions, and that's what the Internet Only Manual, or IOM, is. They use the Medicare Benefit Policy Manual, Chapter 10, to define the Medicare benefit and to explain what must be there in order to make it payable. They use the Medicare Claims Processing Manual, which is Chapter 15, and this manual explains how we as a manager look at the claims, what information must be there, such as your origin and destination modifiers, and other pieces of information that are required. So each item has its own purpose. So what are we going to look at? We're going to start breaking down that first statement. Remember the Social Security Act with the Code of Federal Regulation? That's what we're going to break down to begin with. Okay. So what is the safe means and what is meant by that? So it does not matter that the patient is having a mental health transport. What we're looking for is why the patient right now today, at this moment, as you're evaluating them, this is the only safe means. That how would their life be at risk if they were transported by a different means? So let's talk about that. Could they go by a wheelchair van, a private vehicle, a ride-share taxi, etc.? Because those are non-covered. On the other hand, when we look at safe means, we're looking at what makes them unsafe. Are they violent? Are they belligerent? Are they not following directions? Are they trying to rip out their IVs, therefore they have to be restrained? Are they chemically restrained? What makes it unsafe for them to go? Are they threatening harm to themselves and acting upon it? Are they just talking loudly? What is going on? And that's where we have to have all of that documentation. So when we're looking at an ambulance, okay, so the question that was asked for the pre-submitted question, sorry, is how does Medicare cover ambulance transports when ambulances are the only thing available? Now, again, it's not that they're available or the only vehicle. Medicare does not cover this just because they're the only vehicle available. We would not consider that medically necessary. When you bill it, you would bill it indicating to us that it's not a medically necessary service, therefore it's not covered under Section 1861 S7, and you would use a GY modifier or a condition code on a UB04 claim form to make sure you indicate that to us. All right, what's next? Well, next we hit the medically necessary portion. And again, as we said, this begins with the EMT evaluation. Now, an EMT evaluation is a lot more than just, oh, I looked at the person, right? That sounds great, but what else did you do? Because did you talk to someone? I.e., you picked them up at a hospital and you talked to the nurse, familiar with the person's condition. Did you talk to a bystander or a family member at a scene or at their home? What did you do to begin this evaluation? Do you have information from a hospital or an inpatient psychiatric facility or a home or a nursing home? Where are you getting this? All of this is what's required as part of that evaluation. Now, when we look at the medical necessity, what we're really looking for is, why is the EMT needed today? It's not just about a physical need. Yes, there are physical needs, right? The patient tried to commit suicide and is bleeding profusely because of slashes in their wrist. Okay, that's one type of need. That leaves mental health. Even though it has a mental health condition, it has a physical condition, has a physical need. When we're looking at mental health, and a lot of the transports for mental health that people question us on are the monitoring transports or the observation transports. These are the harder ones to prove because the EMT really does have to show the need for them during that observation or during that transport. What are they doing? Why are they needed? An example we gave earlier is this person's in a chemically induced situation, whatever that situation is. Okay, well, it's a chemical restraint. Therefore, we can't just, hey, go ahead and go. Okay, explain that. What is the chemical restraint? The medication used? What's going on with that? Are they trying to attack people? Are they belligerent? Could they go into a car, but if you put them into a car, they're going to attack the driver while driving down the road? Are they going to try to jump out to commit suicide? These are the things that need to be documented. what's going on during that evaluation? What have you been told and what have you found out? Yes, part of the medical necessity can include previous actions or previous understandings, but it alone does not justify it. We have to know what's happening with that patient immediately right now. And if you don't have any information on that, you will not be able to prove medical necessity. We did receive a variety of questions on the physician certification statement, PCS. I will let you know that CMS does indicate that a PCS alone does not make a service medically necessary. So even though you have one from a medical professional stating this transport is needed, you still need to tell us what's going on with that patient today with the assessment. You can use the PCS as the basis for an evaluation. You could even state, I concur with the PCS, I concur with the findings, we evaluated the patient, we looked at them, we tried to talk to them, they're incoherent. All of those things are fine, but then you also have to supply the PCS. Anytime you mention it in a manner, we need a copy of it. What did you learn? What did you know? And what did you not know? One thing to note with medical necessity, after the fact reports do not prove medical necessity. We have situations where people have tried to prove medical necessity for mental health transports when they arrive at the ER and they're using an ER report. Well, how did you treat the patient with that information during the transport? If you didn't know it, then how did you use it? So that's one of the key things. I'm not saying don't include it. I'm not saying it couldn't help support, but it will not prove medical necessity. And that has been a couple of the denials that actually have had medical necessity for mental health are based on the fact that, hey, you didn't even know this at the time, and now you're trying to use that to support it. Okay. One of the other things that was asked is, are there destinations that can be covered? And the answer is absolutely. So there's not an alternate destination list. There's not a special destination list for mental health. These are just the standard destinations. And yes, you do have to go to one of them. Commonly, we see transports to hospitals, inpatient psychiatric facilities. This could be from an ER. This could be from a nursing home or a variety of others. We see patients who are going home after a certain treatment or after a certain condition and they're calmed down, but they still need monitoring. We also see nursing homes as a destination and an origin. So these are our common ones. Now the complete list is in chapter 15. And the next question that came in regarding the destination is, what if my destination doesn't fit any of these descriptions? The answer is, then it's outside the regulatory requirements and Medicare will not cover that. The example given was they took the patient to a physician's office. Well, why did you go to the physician's office? Because Medicare states it may be a mental health condition, which they may need psychiatric counseling for or whatever the situation is, but that physician's office is a non-covered Medicare destination unless there's an emergency stop on the way to an otherwise covered destination. So the patient's on their way to the hospital, crashes, and you stop at a physician's office because it's the nearest thing and you need the medical treatment right now, that would be covered. On the other hand, taking them there for counseling or taking them there for a psychiatric evaluation are not covered. And no, I can't tell you when they're going to be covered. I don't know that. That's part of the law. So you have to get the regulation changed to cover it. You have to get that regulation changed. So again, the question about alternate destinations, and that's literally what you put in there. I don't have any information on that. I'm not sure what you meant by alternate destinations. So if you could add more information into the chat, great. Which brings us to our first set of questions. And as I said, I will break multiple times, but what I want to give you guys the opportunity to do is to put questions in the chat at this point. We've gone over some of the basic benefits and some of the basic things. We're going to get a little bit more into the documentation elements next. But while I gather questions and have Leanne get ready to ask those of me, I will give you some pre-submitted questions and then we'll go on. So is there any special processing for mental health ambulance transports? No, we do not have special processing. We do look at medical necessity. We do look at the EMT assessment to prove medical need. We do not look at a diagnosis code. Ambulance providers are not able to diagnose, therefore we don't use that. Now it is required on a claim that is submitted electronically. It's a standard requirement. So it has to be there. What you'll do is code your signs and symptoms. So when we look at special processing requirements, the answer is no. It's really going to be based on the next section, which is the documentation. Next question, is anxiety considered mental health, and are all anxiety transports necessary no matter how slight the anxiety is? So first, yes, anxiety would be a reason for mental health. We do understand that. Sometimes you're unable to tell when the person's having an anxiety attack, or is it a heart attack, or is it something else going on? So though they have a history of anxiety, you're going to treat them for the more severe condition just to keep them safe. That's okay, but you want to document that. The answer to all anxiety transports, Medicare never says all on a transport. What Medicare says for a transport is stop. Each one has to individually be proven in the documentation, and each assessment must show this. If a patient feels that this transport should be covered, they can appeal it after you've billed it, even if you bill it as non-covered. So the answer to are all anxiety transports necessary? No. The EMT must evaluate the patient and show us why they believe there was a medical condition or a medical reason beyond just they have anxiety. Just having anxiety does not make a transport covered. Can a patient with a mental health complaint sign for themselves is our next question. And the answer is it depends on the complaint. It depends on what the EMT sees. So if a patient is rational and they're of sound mind and body and you're talking to them and they're able to communicate with you, there's no issues, yeah, they could sign for themselves just because they have a mental health complaint. Okay. On the other hand, what if you're evaluating them and you really can't find that they even have a mental health complaint? Maybe their spouse felt like they did, or the spouse said they were depressed. So we don't know that. Keep in mind, if they are combative, if they are threatening suicide and telling you how they're going to do it, and they're going to jump out of the ambulance, right? Great. Do you want to try to have them sign themselves? Not always, but that does need to be documented as well. So you can hear what I'm saying, and hopefully you're gathering this. The documentation becomes a key and critical component. I do want to ask again, do we have any questions before I move on to documentation?
Tom, we do not have any questions in the chat at this time.
All right, so hopefully I'm hitting everything you guys have asked me so far. If not, please make sure that you are putting those back into chat for me. All right, next section actually looks at documentation. Now I did get some really questions on documentation, and so that's why I built it the way that I did. So like documentation, what's required, what's needed, and what makes it medically necessary. I wanted to also go back and step back, because during documentation reviews, we have some very basic things that sometimes cause issues and make us not even look at the medical necessity. So when we talk about documentation, I really wanted to hit and address all of those, okay? So the first question, which is an interesting one, is how? How were they transported? So can you tell me that? And keep it very simple. Was it air? Was it ground? What was the level of ground transport? When you look at air, was it fixed or rotary? Was it based on a dispatch, which is emergent or non-emergent? Was it based on the fact that you found them sitting there? How were they transported? That's just your basic starting point. I did a ground transport, no lights, no sirens, but emergent. That's fine. We don't require lights and sirens. We do require to know whether it's emergent. Now remember, even for a mental health transport, emergent and non-emergent are based in how you are dispatched and whether you need to respond right now or whether you have time. A lot of people have questioned emergent saying, well, it's in prep to respond, but I don't have to respond for 3 hours. That's not going to be considered an emergent transport. I understand you started getting ready, but you have 3 hours before you have to be there. You're okay. You're probably not going to get that paid on an emergent transport. So when we look at it, answer the basic questions for how. Was it air, fixed or rotary? Was it ground and at what level? And then was it emergent or not? If you've answered those 3 questions, nothing to do with your evaluation. If you've answered those 3 questions from your run report, you've got that element met. Okay. Next, we move on to who. And who is a bit more complex than just one person because there are multiple who's involved. Again, this seems pretty basic though, but I'm going to tell you the patient is one of the problems. The patient's name, date of birth, and Medicare number. If we don't have all of this and we can't figure out who they are, we can't even consider a claim. We won't even put it through the processing system. It's going to RTP for the UB04s. It's going to go unprocessable for CMS 1500. This sounds very basic, but it's one of the biggest problems we have. We don't know who the patient is. Also, the treating and assessing EMT. We do not need to know who the driver is. If the driver was not involved in the treating and assessing of the patient, we're going to assume that they had a driver's license and we're going to assume they were qualified to drive the vehicle. Lots of times it'll be included in the run report, but we don't necessarily need that information. On the other hand, if the driver did the assessing, but the treating was the other person on board, then we need both of them because the assessment was done by one person and the treatment was done by a different person. If the treating and assessing is the same, then we just need their information. I want you to notice that it says certification level. This can be basic, intermediate, however you terminate or use that terminology in your state. It may not be the word intermediate, or it could be paramedic. We need this to make sure that this person is then qualified under a state licensure, which does have to match some other things. So we want to make sure that they're able to perform the service that they're doing. So when you bill it, is this person able to perform an advanced life support, and how that assessment work with this patient's or with this person's criteria, this paramedic, this treating person's criteria. So it is important to understand with who that is there, and you do need to remember to put all of those different components. All right, what happened? Now this is one that starts when you first find the patient, and it actually starts at dispatch. What happened with this patient, right? So, hey, I was dispatched for an attempted suicide. I got there, the patient's walking around carrying a suitcase saying, I need to go to the psych ward. Well, that's a very different what, but I need both of those whats. What happened? What caused you to assess everything, right? So we're going to get to the why later, but what caused you to assess it? What are you seeing? What's happening? Also, a lot of people use time charts during this and say this is what happened at which increment, and that's great. That's perfectly fine for this portion. Really, what we're looking for is what activities occurred when, why did they occur, but the why can also be part of another element, and that is literally why. So if you gave me a timeline and it just said this is what happened, here's each increment moment, this is when we monitored, check their breathing, this is when we did this, that's fine. That's one of the elements that we do need. Very rarely is this one missed. Now the next one, on the other hand, is one that is sometimes missed. And it's missed because it's multiple components. And this is when, date, and time. So yes, I need the pickup date, especially when the pickup date and the drop-off date are different. Sure, this can happen. You pick someone up at 11:48 p.m. and you drop them off at 12:02 a.m. That's 2 different days, 2 different calendar days, and we need both of those. When was the assessment? When did you do this? When was the transport? How far was the transport, right? All of those basic things. So we need to know the when. When did everything occur? Now the where is the one that will give us the mileage. So where are your addresses? Where did you pick them up and where did you drop them off? Had a question come in on the where, and I want to talk about this one because this is the problem with the where. I pick them up, but I don't actually have a good address for this. You still need a zip code for the pickup, no matter what. And we do have a defined list from CMS. I mentioned it earlier when I mentioned the destinations. The same list is used for origins. What happens if it doesn't quite fit in origin, or you're like, not really sure? You're going to have to pick the best one you can. We have to have an origin code. Now, a destination or a drop-off code, we have a physical address. You should not be dropping them off in the middle of the street, like just randomly on Highway 101. That doesn't work. What you want to do is give us more of an address. Could be a homeless shelter. Fine, that's still an address. You took them somewhere as a destination. Now, Medicare may ask, why did you take them to a homeless shelter, or what was the point in transporting them back there? So there's a variety of different other things that will play into that, but that'll come next. We need a street address, and we do need a 9-digit zip code for the drop-off. Now remember, the point of pickup zip code, and the reason that we ask you to put this in is that it is what is a driving factor in the Medicare ambulance fee schedule. Not the drop-off location, but the pickup location. So we have to have that. So someone asked a question, and it was a good question. What do I do if I find someone sitting on the side of a street? I don't actually have a pickup address. Use the closest one you have. Okay. You use the best one you can for that location. So maybe what are they sitting next to? Is there a park that would have an address that they're sitting by? Are they sitting on a bench in a park? Use the park. Are they wandering down highway A1A and they're between mile marker approximately 120 and 121? Are they on the interstate and they're between a mile marker? Give us the best you can. Once you do that, you may need to map it to a farm that's close by or another type of address to get the best you can. What city or zip code would it fall into? Without that information, we will not be able to properly process your claim. So to answer your question, if you find them sitting on the side of the road, tell me about the side of the road in the documentation. And then when you translate that to go with the best address or the best zip code you can. We do understand that you will find people with mental health conditions literally sitting on the side of the road. There's no real dispatch. We'll talk more about that in just a moment. All right, so why? Why are you doing this transport right now? This is your biggest component. It's also going to be the hardest one to prove for mental health because the EMT has to evaluate and show why they are needed. Doesn't matter what level they're at. Why are they needed? Sometimes it's fairly obvious. This person is attacking. This person is belligerent. This person is out of control. This person is threatening to harm themselves. They've tried to jump out of a vehicle 3 times. When the police loaded them, they, were physically causing this, this, and this. All of those should be documented to explain why the EMT was there. They need to physically be restrained in a bed versus just the handcuffs because they're willing to try to jump out of the handcuffs or they're willing to try to break their arm to get the handcuffs off, harm to themselves or other. That's why they couldn't safely go by a police officer. That's a different form or mechanism, right? So why becomes our biggest thing? Things to note. We do need a dispatch reason. Okay, now, if you said I found them on the side of the road and there was no dispatch, that's your dispatch reason. Found sitting on the side of the road. We drove by and they were randomly sitting there, staring into space. They were whatever the situation is. Be careful with that and make sure you document why it was needed and why it wasn't just a homeless situation where the person was literally sitting on the road, or was this person sitting by a park waiting for someone to come and pick them up? So when you document that they were there, you want to make sure it meets a dispatch reason or something that will help us understand what's going on, okay? Remember, the why, though, needs to be based in the assessment. The assessment is so much more than just saying, I looked at the patient, right? The assessment is taking this information from everyone around you. Believe it or not, this is one of our biggest missing elements. And it's what's going on with that patient. What are you seeing? What are you smelling? What are you hearing? What are you being told? Because all of those add to the why for a mental health reason. Yes, part of the assessment is to look at the history of the patient as well. Please include whether or not this patient has a history of attacking when in an enclosed space, whether they have a history of having anxiety disorders or whether they have a history of having panic attacks, whether they stop breathing or hold their breath for a period of time until they pass out. What's unsafe about this patient being transported? That's part of the assessment and part of what needs to be there. It can also then justify. Now, again, history alone won't make it qualify if you just don't give us anything more than the history. So it's important to look at the patient's condition today. Right? Which brings us to that lovely assessment. And I think you guys have heard me say this a lot, but I will continue to say it. So when it's time to assess the patient, what does Medicare look at? Now, this isn't necessarily very different from a regular assessment, except for a couple of things. So one, what do you know at the time of transport? First, establish whether or not it's a medical transport. The example I gave earlier was a patient who is trying to kill themselves and says, I took a bottle of pills, or I took all of this stuff. that may be more of a medical transport, and you may need to state, okay, they took these pills, this is what they're reporting. On the other hand, they can say, I'm going to commit suicide by drowning myself. Okay, well, what's our plan there? And they don't really have anything, and it's just what they're going to do. I'm not saying don't transport them. I'm saying go a bit further and see what's going on with that patient and explain a bit more. We don't see with the drowning themselves an immediate need. Now, the one that I did see come in, and it was a mental health transport, and the patient said, I'm going to commit suicide by jumping out of the ambulance as you pass over the river and drowned myself. Wow, okay, this person has a plan. They've got a goal. They knew what they were doing. So this one makes it a bit difficult. They did need to be restrained because in conjunction with that, they needed to have a physical restraint done because they were attacking the EMT on a regular basis when they tried to take their blood pressure. They were combative. They also swore and refused to answer questions. So there was a lot more going on with that one. But that was an interesting situation. I thought I would share that with you as well. So again, what is the immediate harm to themselves? Again, are they combative? Are they cooperative? If they're cooperative, why? And that sounds very basic, but if you're picking them up at an emergency room and this person is cooperative and they're not combative, but that's because they're medicated to a certain point and that's what's causing this, okay, help us understand that so that we know that, hey, what happens if this medication starts to wear off during the transport? What happens during that time if we are unaware of that? Can they communicate? I know every single one of you that is an EMT has shown up and tried to talk to a patient and you have no idea what they're talking about. And they're rambling and they're talking about something, a little off the wall. My friend Amy's an EMT and she likes to use the story about the guy who was talking about the alien that was coming to inject him with the green solution and how he would just inject himself with it. Well, the green solution that he was talking about is actually antifreeze. And he was going to inject himself with antifreeze to stop the aliens from doing it. Okay, well, there's a whole lot going on with that statement. So it's just something that, we've looked at and we've seen. Also, again, we talked about relevant history or relevant information. Is this something that you should be looking at when you look at all of these different things? So let me give you a few key questions to ask yourself as you're reading through the assessment. If you're auditing the assessment, one, is there a physical or a medical need for the transport? If there is, then that's the transport. It's not necessarily the mental health condition. It could be secondary or it could be an additional need. Is there a medication or a sedation issue? If so, what is it? How did you find out about it? What medication was given? What sedation was done? Is it physical? Is it chemical? What are we doing here? Now, when I say physical, have they been attacked and there's something going on that puts them to sleep because they have energy expels? There's a variety of different things. Keep in mind, we do want you to answer the question, is the patient angry and is the patient combative? If you say, nope, they're calm, but every time we try to touch them, they start flailing and screaming and okay, they're calm, they're not angry, they're just having some other thing going on, let us know that. Also, when you're talking about combative or angry, how are they displaying this? What are you viewing? What's going on? Help us understand what we're seeing or what you're seeing so that we can get a better picture. When we look at one of the key items is what risk does the patient pose to themselves or other at this moment right now for this transport? What's going on? And then any other history. Can I look through this information during this assessment and was there a piece of history or something given that helps explain what's going on or helps explain why we're doing this? So we don't use that alone. We do want to still look at the patient. The patient's calm until you go to put them onto the bed, until they go to get in a vehicle and they start screaming and hollering and okay, now they're having a complete breakdown and explain what that breakdown is, explain what the act are occurring you to use the term breakdown. All of that is what's going on. Oh yeah, by the way, then the spouse told me that the patient has severe anxiety or has this, and by putting them into the car, it triggers them and they'll attack the driver. Okay, well then you want to also put that in his history. That's something you found out. So when we look at it, what we're looking for is the assessment and why EMT is needed right now today. If you cannot justify why they're needed, if you cannot figure that out from this documentation, you will not pass a Medicare medical necessity check. You're not going to pass that documentation review. But again, we will assume that you will pass it unless we're told otherwise. Next series of questions, and I'm going to address these kind of all lumped them into one. One of the questions or one of the big concerns was the PSC or the physician certification statement, especially when coming from like an emergency room to another facility or times when you may want to get it. Now, first, for a mental health transport, is a PSC required or a physician certification statement required? And the answer is not always. It depends on one, where are you picking them up at? So if it's required, yes. Also remember, it must be there for a routine scheduled transport. So you're taking them to a psych facility. You know this is going to happen. It's going to happen in 3 days when they're discharged from the hospital. Now they're stable. Everything is good. And we're going to do this. Now, why did I shouldn't say 3 days. I should say 2 days or tomorrow, 24 hours in advance. That's scheduled by Medicare rules. On the other hand, if it's a one-time transport, which could be the transport to a psychiatric facility, it doesn't necessarily need to be there. Now, I say necessarily because what if it's to the psychiatric facility, but the psychiatric facility can't do the dialysis? So they're leaving the psych facility and going back. You know those are going to be scheduled. The patient still has to get dialysis. So we don't want to stop that either. Okay, so there would be a time when it would be an example. So is a PCS always required for this type of transport? And the answer is no. If there's no physician's involvement, you're picking them up at the home or at a scene, or you find them on the side of the road, where are you getting this professional involvement? Maybe you have one, maybe you don't. It's not always required. So if it is required, if it's a one-time transport or a non-scheduled, could you get a PCS? And yes, you can get one. So you're picking them up at the ER and you're transporting them to an inpatient psychiatric facility, or you're picking them up at a hospital and transporting them to an inpatient psychiatric facility. Now, I said you could get one. Well, what happens? Well, it was unscheduled, so you went to get them, didn't have 24-hour notice, and it's only a one-time transport. You could get one the day of. You could also make multiple attempts to get one after the fact, okay? After the fact. But if you can't, could you bill Medicare? The answer to this is yes, and the Code of Federal Regulations provides for this. So please make sure that if you're looking at this, you want to go back to that Code of Federal Regulations on slide 8. Take a look at 410.43, and then it's 4, section 4, 3, section 3, 4. Yeah, section 3.4. Wow, that took me a while to get it out. I apologize. Inside there, it will allow you and it will tell you have to have multiple attempts. If you don't have the attempts and they're properly documented, you can bill without it. So you do need a PCS, or you need to attempt to get one and have proper documentation of the PCS. But the PCS alone will never support the medical necessity. It will help you determine what should be in the assessment. What should you have looked at and what should you have an understanding of before transporting this patient? That's the goal of the PCS. Because remember, they can be written in advance of the transport as well. And the example I gave there is a mental health transport. The patient has issues or problems or situations arise that during the transport they couldn't safely go by any other means, but they still need to get to their dialysis, right? Yeah, we would still need a PCS. Yes, it could be the attending physician. It could be someone familiar with the patient in terms of making sure they get that type of care. Okay, so hopefully I answered those questions well enough, and if not, please put some information back into the chat for me. Which brings us to our next set of questions. And our next set of questions, we're going to talk again about some general pre-submitted questions. I'm going to ask if we have any questions, so go ahead. This is your opportunity to throw those questions in the chat. So one of the questions relates to the diagnosis. What are the best ICD-10 codes to use for mental health transports? Now, once again, we as a MAC do not provide a list of ICD-10 codes that support any mental health transport or any transport in general. Other MACs may have local coverage determinations which are specific to them and may do this. We do not. Here's how the best one is to use. Look at the patient today, read through the signs, symptoms, what's happening with the patient, what do you know about the patient today, and assign a code based on that. We do not edit or stop claims from paying based on a diagnosis code alone. Don't do that. Our system, our edits are built to allow for those claims to at least be considered when we move through a variety of other things. you said I used an ICD-9 code. By the way, that is a common denial, and yes, we're still getting those. If you use that type of a code or an invalid code, meaning it got changed at the beginning of the year and you didn't change your code books, we will not process that. But that's not the same as which code is best to use. Again, signs, symptoms, what are you seeing, what are you doing? That's what you want to code. So it's all based back in that documentation, okay? Does Medicare cover psych evaluation for transports from the behavioral health facility to a hospital? Again, tell me a bit more about this because it's a psych evaluation, I don't know if it's going to be covered. What's going on today? What's happening right now with this patient? So just because it's for a psych evaluation, doesn't matter where it's going to be at, we need to know a bit more than that. So help me understand, give me a little bit more information, use that assessment, use the tools we've given you, things like that. Leanne, do we have any questions in the chat?
Tom, no, we do not have any questions at this time.
All right, well, let's keep going. This is the section that was built for your questions and your answers and what you pre-submitted. So based on those, I tried to lump them together to make them best work through. So hopefully this will make sense to you guys as we get going. But again, if something doesn't quite work, let me know in chat. I'll get those answered for you at the end. Okay, number one, specific items. Where is the list of specific condition that Medicare will automatically cover for a mental health transport? Look at the word automatically. What did we talk about with this one? First of all, CMS has nothing automatic about this. While some contractors do have local coverage terminations, WPS does not. Instead, we want to consider these on a claim-by-claim basis with the assumption of coverage, unless you tell us otherwise. So there is no specific item or list of coverage that you're looking for. This would be done through the LCD, and we don't have one. Next question. We have a local regulation, being whatever it is, and this local regulation requires us to transport any patient calling 911. Does Medicare pay for this? Okay, no. Doesn't mean we won't pay for that transport or we won't consider that transport. First, when you get there, what did the EMT find? What did the evaluation establish? Local regulations do not override the Social Security Act. They don't override that. So we still have to have the Social Security Act. If you put in and you said, hey, I got this and it went back through and it went through one of the medical review post-pay processes, they can actually say this was done due to a local regulation. It's not going to work. We're still going to have that not get paid. This does not mean that a patient can't appeal it, and for whatever their reason or their rationale is, they can get it paid. And I want to make that very clear because how it's looked at is differently when you look at and you get to a level 3 when they look at the law. They can look at the spirit of the law at the administrative law judges, and they can look at a variety of other factors, and they can pay things that we cannot. So, okay. All right. Let's keep going on with this one because the next one is actually an interesting question, and I do have something that will help you. The next one was actually came in, and it's regarding the end of my slide move.
It did.
And can you tell me which slide you're seeing? Okay.
And see PCS help.
Perfect. Okay, that's where I want to be. Sorry, I wasn't really sure what was going on there. The question is that they're struggling with the PCS and they're struggling to get the needed information because a PCS is required, and if they don't have it, they still have to use it. Here's what we've done. We've developed a sample form, and I've given you a link directly to the sample form on the slide. Our goal is with this to provide every piece of information regardless of how a PCS could be used. So it could be the unscheduled or the one-time transports. It could also be the scheduled non-emergent. What we've done is gone through and looked at with our medical review team and our appeals team and said, what do we really need to be able to use this PCS that will help drive this? And that's where all these different chunks and questions and things came from. It is available on our website in the claims section. If you're not familiar with that, you're going to come to WPS, Government Health Administrators, select your jurisdiction. I'm just going to use, we'll just use J5B because it's exactly where I'm at this moment. And then I'm going to say, hey, I want to go to my topic center. I'm sorry, not claims, it's a documentation. We're talking about a documentation item. So documentation, I don't want to give feedback, but I do want to accept this. Even one more, okay. And then I'm in forms right here on the top. And inside the form, you'll be given the opportunity to download a physician certification statement. And this is just a sample form. It's not anything that's complex. It's just available to you, but it is something that is available to you on the slide as well. The form will help you through that different questions that you have regarding that. So I would like you guys to take a look at that if you need help. So documentation. And do I have any documentation tips? First, please start with the basics. I mean, really go back to the basics. Is it signed? Is it dated? Do I have the patient's name? Do I have the patient's Medicare? Can I tell who all those are? Because that is one of the biggest errors that we reject for. Sounds weird, but we never even make it to medical necessity. Always include information today. Okay, for today. Again, when we talked about the assessment, we said, tell me what's going on with this patient right now. Okay, what's going on with this patient right now. History may support the claim, but it may not be enough alone, because if they're fine today or something's not going on today, how do we know that? What does that history mean? And we better have the documentation. So just explain their current mental status. Is there confusion? Are they not talking or communicating? Are they frustrated? What are the signs that they're showing that frustration? Are they depressed? What are the signs that they're showing that depression? All of those different types of things. When we really look at it, that's what we're looking for. The next one we put in very specifically for suicide attempts, and the question that was asked is, does Medicare Part B cover sports due to suicide attempts? This is too general of a question for me to answer. I mean, we don't automatically cover it due to a suicide attempt. Can you tell me what's going on right now? What is the current status? What's going on with this patient? What did the EMT see? Are they in an active suicide attempt? Was this a previous attempt? Are they reporting something like I took a bunch of pills? You know, okay, you're going to add on that. What are they throwing up due to those? What are we seeing and going on? So to say, we're going to cover it automatically because there's a suicide attempt, we just need to know a bit more information. All right, which brings us to the last set of questions. We do have a couple of minutes, so I'm going to go ahead. I have a couple pre-submitted, then we'll go ahead and hit up those chat questions. So, how does the patient sitting on a bench seat factor into the medical necessity? Really, it doesn't factor into it. The fact that they're sitting on a bench or a seat or on the park or on a curb, it's not what we're looking for. We're looking at the evaluation. Why did the EMT need to transport them? Why were their skills required? And what does sitting on a bench seat matter? Could they not stand? Were there a variety of other medical things that may help prove it? So just saying sitting on a bench, sitting on a seat, sitting on the curb, these aren't necessarily factors. They're contributing and they give us further information, but they aren't alone going to prove medical necessity. Are there certain forms required to have that necessary transport? No, Medicare doesn't have any certain forms unless you're talking about the PCS and when it's needed, in which case it would be for a scheduled transport, scheduled routine transport more than once. If you're talking about a non-scheduled or a one-time transport, then no, it could be used, especially depending on the origin. But if you don't, could you get the documentation to show why you don't have it or why you made several attempts to get it and still didn't? Yes. But remember, there's no specific form that will prove this. It says, oh, this is medically necessary, check and go. We don't have that. What types of mental health diagnoses would be covered? And the answer is anything can be covered depending on what you document within the assessment and what you see. Can you bill Medicare for a transport from a SNF to a direct admit to a psych facility? Example, geriatric behavioral health center within a hospital, bypass the ER and go directly to psych. Yes, if that is the situation, absolutely. A SNF person, is still a medical professional. So if that doctor says go here, okay, great. If the nurse or another medical professional is saying take them to the psych facility, this is where we need them to go. Yeah, you're still going to do that. Yeah, you're going to do that because that's what the medical professional is telling you to do, right? The basis for the transport, it is a recognized destination, but the basis for the transport is still going to be in the medical necessity. So hopefully that makes sense to everyone. With that said, that's my last pre-submitted question. And so, Leanne, do we have any other questions?
We do have a question in the chat, Tom, and is asking if a legal petition and cert removing patient rights impacts medical necessity.
Oh, good question. And the answer is no. Just because you say that the patient doesn't have the right to do certain things or make certain decisions alone, that won't necessarily impact their rights or the medical necessity for the transport. It could impact their right to sign for the transport, in which case you'd want to document it and then tell us why you had a different method of signature or why you got it after the fact or why they didn't sign. But in terms of medical necessity, no, that's still based on the EMT evaluation. Any other questions?
There are no other questions at this time.
Okay, here we go. We're going to finish up. There is a National Provider Enrollment Conference. If you're interested, I do recommend taking a look at that. There's a link on this slide. There's a link in the description. It's on August 20th and 29th, so coming right quick, but you can still register and you can travel to San Diego for it if you want to. I'll cover everything related to provider enrollment, so it's just a great opportunity. And that brings us to the end. We're done. Thanks for attending. So I really do appreciate you guys attending. I appreciate your time and the time that you've taken today to listen and to hear. And hopefully you'll take that survey, give us the feedback on today's event, tell us about future events, all those different things. If you have further questions, the survey is an opportunity to put those in as well. So again, thanks for attending. Review our live events page for more upcoming ambulance education. On behalf of myself, and all of provider outreach education, we look forward to your surveys. We hope you'll attend more education in the future. Thanks, and you may now disconnect.